Hi everyone, my name is Stefan. I'm a pulmonologist and interstitial lung diseases physician. In this video, I'd like to discuss a little bit about sarcoidosis, which is a bit of a mystery disease. It's an interstitial lung disease as well, because it affects the lungs in most cases as well, and it can cause fibrosis of the lung. So I want to just give you a couple of basics on sarcoidosis because it's a bit of a misunderstood condition. Like I said, it can mimic many other conditions. It's a bit of a mystery. Usually patients struggle to get a diagnosis early. It's a bit of a struggle for both doctors and patients to understand this condition. So I hope this video, is a little step in that direction of understanding what sarcoidosis really is. Before I start though, because the internet is obviously open to everyone and these videos can be seen by patients as well, I just want to say a bit of a disclaimer, because the information presented here or in other videos on my channel, this is not medical advice. So please see your doctor if you have any health concerns like I've written here. I think that's really important to say before I start off. But let's talk a little bit about sarcoidosis, and you might find this useful if you are a medical student, perhaps, or if you just are seeking some general information about this condition, if you're working potentially in another area of medicine, or if you are a patient. It's good maybe for general understanding. But like I said, do see your doctor if you do suffer with sarcoidosis to get personalized advice, because you may see later on that it is a bit of a complex disorder to deal with and you need appropriate care and follow-up. So first of all, it is a systemic disorder, meaning that it can affect most organs of the body. So it's a condition that's general. It can affect any organ of the body, not only the lungs, although the lungs are most often affected. It is also something called a granulomatous inflammatory disorder. So it's an inflammatory disease. There's inflammation in the body in the form of this granulomatous inflammation. I won't get into a lot of detail here because there's plenty of information out there about what this non-caseating granuloma is, but this is basically the pathological feature. And if you're a doctor, if you're working in a hospital, perhaps you might come across histopathological reports mentioning this non-caseating granuloma. And this is basically a feature of sarcoidosis which can be found on biopsy samples. So this is something you might be looking out for if you are trying to figure out if a patient has sarcoidosis, or patients may be referred to you with this result if you're working, for example, in the respiratory field. Now, sarcoidosis has a variable incidence, but it's not very low. As you can see, up to maybe 50 people per 100,000 can be diagnosed with sarcoidosis as new cases, basically. So there is no known cause for sarcoidosis. It's thought to be an interaction between environmental factors and a genetic predisposition. Bit of a mystery here because there have been clusters of sarcoidosis patients described. So again, there might be some sort of an environmental connection, sort of a familial connection, but this is not very clearly defined as of yet. Now, the symptoms of sarcoidosis obviously are a bit non-specific because it's a systemic condition affecting potentially all organs of the body, but we do have inflammation. And usually when we have chronic inflammation, we can have low-grade fever, we can have night sweats, we can have joint pain or arthralgia as they're called, fatigue. Also, there can be organ-specific symptoms depending on the organ which is involved. Now, there can be acute or chronic forms of sarcoidosis and presentations of sarcoidosis. The acute form, most widely known, is something called Löfgren syndrome. So basically this consists of a grouping basically of signs and symptoms. So fever, bilateral hilar lymphadenopathy, which can be seen on an x-ray, ankle arthritis, and erythema nodosum. Now, chronic sarcoidosis basically depends on, the presentation will be different depending on the organ which is involved. So for example, if you have lung involvement, you may have a patient who has cough and dyspnea or shortness of breath. Now, obviously, the diagnosis does require a few steps. First of all, you need to have a consistent radiological and clinical picture. So things should look like sarcoidosis, first of all. Then in most cases, we would need to have some histological evidence of this non-caseating granuloma that I mentioned before. So a pathology report might outline this in most cases. Now, the biopsy can be done in various places depending on where the involvement is. And it's absolutely important to exclude other causes which may explain the clinical presentation. So the initial evaluation basically will consist of a baseline assessment of disease distribution to figure out which organs are affected and then to focus on the most affected organs. Now, obviously, it's a bit more complicated than that. So basically, we should aim to provide histological confirmation in most cases if we can, because we can diagnose sarcoidosis clinically sometimes, but we're never that sure that that's the right diagnosis. Now, we need to, like I said, assess the extent and severity of involvement. So not only just to say, yes, we might have involvement of the kidney, liver, etc. We must know how severe this involvement is. And we need to determine also whether the disease is stable or likely to progress, as you'll see in the next few slides, that there are quite a few things that we need to look out for. We also need to understand if therapy might be beneficial for the patient, because sarcoidosis doesn't need to be treated in all cases, as you will see in the next few slides. And this is very important to mention because the finding of an isolated granuloma, so this non-caseating granuloma, is not a proof of sarcoidosis in itself, because this can be caused by other things as well. So if someone refers a patient to you with just a pathological result, but no clinical symptoms, no other findings, you need to look for other causes as well. You need to have a broad differential diagnosis. Now, the confirmation, like I mentioned, can be done usually based on some sort of a lung biopsy. This can be done in various ways. So like I mentioned here, a few options can be if the lung is indeed affected and there is no other more suitable site for a biopsy, such as, for example, the skin, the lip, like I mentioned here, a superficial lymph node that's more easily accessible. Usually the patient needs to undergo some sort of a bronchoscopy. And usually the bronchoscopy can be done to have a small lung biopsy, a transbronchial lung biopsy, like I mentioned here, or it can be a mucosal biopsy only, and that can sometimes provide the diagnosis, but it's not always confirmed, even if the patient undergoes the bronchoscopy, because we may not get the granuloma in the actual sample. Because the lymph nodes in the chest are affected, usually this type of bronchoscopy, which is called an EBUS-TBNA, which is a specific type of bronchoscopy where we use an ultrasound probe in the airway to figure out where the lymph nodes are, and then use a bit of a needle to sort of do a biopsy through the actual wall of the bronchi. Then we can get a sample that way, or we can sometimes do a surgical procedure which is called a mediastinoscopy to obtain a lymph node sample. Like I mentioned here, so these become increasingly more and more invasive. Now, obviously, simple bronchoalveolar lavage can sometimes give us a bit of a clue that sarcoidosis may be involved, especially if this lymphocyte CD4 to CD8 ratio is increased. Now, obviously, this is not a confirmation in itself. Again, we wouldn't get a granuloma from a BAL, a bronchoalveolar lavage. But if we can biopsy another site, that's usually easier for most patients to also deal with. So for example, if we can have a skin biopsy, if there is skin involvement with sarcoidosis, or lip or superficial lymph node, that can be helpful as well. Now, it's important to note that in acute presentations, sometimes a biopsy may not be required actually. So that's something to keep in mind as well. Now, there are some blood tests that can support the diagnosis, so these findings can sometimes be arguments in favor of sarcoidosis, not necessarily caused only by sarcoidosis, but something to think about because it fits in the little bit of a puzzle that we have, the diagnostic puzzle of sarcoidosis. So an elevated angiotensin converting enzyme, this can be seen in, I would say a majority, more than half of patients with sarcoidosis, but not in all of them. But it can sometimes be there. An elevated calcium level also can be supportive of a diagnosis of sarcoidosis, and depending how elevated the calcium is, this may require some form of intervention. Low lymphocytes is a pretty frequent finding, I would say, for patients with sarcoidosis. So if you see this on a full blood count and the symptoms are compatible, other findings are compatible, it's again an argument in favor of the diagnosis. Now, there is also the need to perform a chest x-ray, and the classical staging system that's been used for sarcoid since the 60s, basically. So this is, I would say, this paper, if you can find it and have a look at it, this paper by Scadding, who came up with this classification in 1961. So this has been through the test of time, and it's still used today. So this is something fascinating if you can think about it this way, because it's a paper published before the age of spreadsheets, of everything else. So yeah, it's an interesting. I would like to say that if you can read the introduction of the paper, you can find it online for sure. It's very interesting how it starts, because it only has one author, and they say, I have done this, I have looked at my cases retrospectively and came up with this classification. So, I mean, it's an interesting piece, but that I'm going on a bit of a tangent here. But basically, there are 5 stages according to Scadding's classification. Now, there is some push to move towards a CT-based classification at the moment, because this is not always correct. Not all cases can be classified in one of these stages. But this is important to keep in mind, because it's still part of the initial evaluation and follow-up subsequently. So basically, stage 0 is where we don't have any chest x-ray abnormalities. Stage 1, according to this classification, we have bilateral hilar lymphadenopathy only. Then stage 2 is when we have this bilateral hilar lymphadenopathy, but also parenchymal infiltrates. So we have both. In stage 3, the hilar lymphadenopathy disappears, but the parenchymal infiltrates remain. So that's stage 3. And then in stage 4, basically those infiltrates turn into fibrosis. So this is a stage where the reversibility of the disease is no longer present. So basically it's a bit too late. So we aim to find patients before they progress through these stages. But obviously this is a big simplification, but I think it's useful to sort of understand the progression of the condition. And if you want to see pictures regarding x-rays, there are some references at the end you can look out for. Radiopedia.org has a lot of articles on this, and there are many resources online that you can find. Now, the CT scan, the computed tomography scan, that's the, well, I would say that's the thing that you would need in modern day medicine. It's required to describe in detail the lung parenchymal involvement and how much fibrosis there is, how much inflammation there is. It can give us clues regarding the extent of the inflammatory involvement, because that is the component of the disease in the lung that would respond to treatment potentially. So it's quite important to have a CT scan if you can. Now, depending on where you are in the world, I understand that can be a bit more difficult, but I think things are progressing, and even in developing countries now, you can sometimes get a CT scan if you need for your patient. It's a little bit more complicated, but it's always useful. It's actually almost impossible to have a proper, modern, accurate diagnosis without a high-resolution CT scan, because this would describe how much fibrosis there is, how extensive the disease is in the lungs, and whether treatment might be required. So it's helpful to have this information. Now, the lung function is also very important to assess, because how the lungs work is basically what you would use to see whether the disease progresses or not. You wouldn't do an X-ray necessarily every time you see your patient. You won't do a CT scan at every follow-up, but you can do simple spirometry, and that usually tells you whether the restriction within the lungs progresses. So that is a good indication that something's not going right. So it's important to get a lung function reading at baseline when you first diagnose the patient, and then you can repeat this over time at every follow-up or every now and then to figure out whether the disease is progressing or not. Most commonly, a restrictive pattern will be seen on spirometry, so basically both FEV1 and FVC will be reduced, but you can sometimes have an obstructive pattern, like you would see in COPD, for example, but that's a bit more rare, and it's sometimes an indication that the disease may be affecting the mucosa of the airways, so the actual airways themselves. So that's quite interesting to also follow. Now, if you can, it's quite important to get a DLCO reading. So this is basically the carbon monoxide transfer factor. If we can measure this as part of lung function, this is helpful. It's a common procedure. It's not something special that I'm mentioning here, but it's not always accessible to most labs, let's say, where you can do a spirometry. It's accessible in developed countries, but sometimes if you're far away from a lab that has this, it's a little bit more difficult, but it's usually the most sensitive to disease progression. So if you can have this done when you do the lung function, it does really help the clinician as much as it can. So yes, that's something that I would say it's quite important to have the DLCO reading and also the FVC and the FEV1 readings that you get from simple spirometry. Now, it's very important to check for some involvement of sarcoidosis that is life-threatening, and one of these is heart involvement. So this is very important to check for. A careful clinical history is the first step, because we would ask the patient about palpitations, which can indicate that there is some arrhythmia present. And as a baseline, it's always helpful to perform an ECG. So you would do an ECG and ask the patient how things are going, if they have palpitations, if they have any sort of signs or symptoms that may suggest a heart involvement. You can even do an ECG Holter, although it's not necessary usually from the get-go, but it's useful if the patient does report some symptoms that might make you suspicious that there may be an arrhythmia present. Now, a cardiac MRI is obviously a test that you would do when you have a high suspicion that there is heart involvement, because that can confirm the diagnosis. I didn't mention it on the slide, but you can also do a PET scan as well, and that could pick up the inflammation in the heart, and that could suggest that there is sarcoid cardiac involvement. Now, pulmonary hypertension is a rather frequent and bothersome complication of sarcoidosis, can happen quite often, I would say. So basically, like I mentioned here, it's when the patient has dyspnea or shortness of breath that's really out of proportion with their pulmonary function test. That's normally when you would think that there may be pulmonary hypertension present. So for example, the patient's really breathless. They can walk for 100 meters, but their lung function is only mildly impaired. So that doesn't really explain it. So you need to look for other causes. Now, an echocardiogram, so a transthoracic echocardiogram, is usually the first step to screen for pulmonary hypertension. Now, we need to also check for other organ involvement. Like I mentioned before, sarcoidosis can affect most organs, most vital organs of the body. So it's important to check for other things. Eye, liver, kidney. So these are things that are main things to look out for. It's also important to look at calcium levels, because very high calcium levels do need treatment because they can cause complications. So basically, I've just summarized here in this slide a couple of useful steps to do when you are first diagnosing a patient with sarcoidosis, because these can really help to not miss things. So initially, it's good to do a careful history, including occupational, environmental, family history, symptoms. This usually tells you whether sarcoidosis can be there. So the careful history is very important. The physical exam, that can usually pick up other involvement, for example, the skin involvement, that can be picked up quite easily in sarcoidosis. A chest x-ray is very important. Like I've mentioned, we can classify in stages based on the chest x-ray. You can use it as follow-up. It's a simple thing to do. Pulmonary function tests are very important as a baseline. So the simple spirometry with FEV1 and FVC measurements, but also the DLCO, if you can get that one, that's usually helpful as well. Like I said, it's the most sensitive one over time to determine whether the disease progresses. A full blood count is very useful. Like I said, low lymphocytes can be a feature of sarcoidosis. So, it's important to get a full blood count at the beginning. Biochemistry of the blood. So basically to get a creatinine level, liver enzymes, calcium, angiotensin converting enzyme. So these are things that can be affected in sarcoidosis. Urine analysis is also helpful to check for kidney involvement. Then an ECG can help as a baseline to check whether there is any sign of cardiac involvement. Obviously, an abnormal ECG should prompt further investigation in these cases. An eye exam is also very important if you can have it done. Usually, it's important if you are sending the patient, if you are referring them to an ophthalmologist to check for sarcoid eye involvement, it's important to mention this on the referral so that the ophthalmologist knows what to look out for. And then if appropriate it's and needed, as in most cases is, it's important to select the least invasive site for a biopsy. So for example, if the patient has skin involvement, maybe they should be sent for a skin biopsy to try to get that elusive non-caseating granuloma, which would confirm your diagnosis. And obviously with all these things, with all this information, it's, I would say, fairly important to go with the clinical information, the history, everything else, all the results, to go to an MDT, a multidisciplinary team discussion. This is usually how it's done. So basically you want to talk to other specialists. You want to discuss the granuloma finding on a biopsy with a pathologist. You might want to discuss the X-ray or a CT scan if you've done a CT scan with the radiologist. So this is useful when you're diagnosing sarcoidosis, and also helps to bring clinicians with various strengths to this discussion to decide on the appropriate treatment steps. So this is quite a comprehensive, I would say, evaluation that you need to do for sarcoidosis. Now, the natural history of sarcoidosis, how the disease behaves over time, is very variable. So it does require follow-up. That's very, very important. I would say that's very, very important. So you can have spontaneous remission in sarcoidosis in up to 2/3 of cases. So that means that patients diagnosed with sarcoidosis may improve without any intervention. And that's something very strange for most disease. And most clinicians are not very comfortable with just a wait and see approach. But in sarcoidosis, it's often the right choice. But it depends, again, from patient to patient. So like I said, a bit of a mystery disease. You need to follow up to see what's going on. There's a significant amount of cases, though, that can have progressive organ damage. So you need to look out for that. So for example, the lung, which is the organ most frequently affected, can basically be involved more and more. There can be ongoing inflammation that leads to fibrosis, which is then irreversible. So you need to look out for that. Normally, you would follow with lung function, potentially X-rays, CT scans, if there is any changes on the lung function. So this is something that you would need to check over time. And then obviously, as part of follow-up, it's very important to see whether there will be any serious extrapulmonary involvement. So like I said, some organs, when affected by sarcoid, need treatment. So if you have cardiac or central nervous system involvement, you might want to give your patient the option to have treatment, because you're trying to prevent damage. So this can occur in not many patients at the beginning, but then it can this can increase over time. So follow-up is very important. That's basically what I'm trying to say with this slide. Now, the adverse features that might suggest bad prognosis, I've listed a couple of them that I could find, but obviously there can be others depending on a case-by-case basis. So the lupus pernio is just basically significant skin involvement. It can be debilitating for the patient. It doesn't look pleasant to have basically a big purple rash on your face, and then that's something that you might want to consider treating for. Obviously, eye involvement is something that you might want to discuss with the ophthalmologist about treatment. Older age, let's say, and the other things that I've listed here. So these are very important to kind of look out for in your patients who might suffer with sarcoidosis. Now, the treatment is interesting because it's a matter of significant debate. Like I said, some cases of patients with sarcoidosis, you don't need to treat at all. So you just need to wait and see, follow up closely and see what happens. And that's usually all the intervention that's required. But that's something very hard to explain to the patient, that most clinicians aren't comfortable to not treat. But this is something that sometimes we need to do. And again, it's on a case-by-case basis. The treatment should be ideally decided by an MDT, a multidisciplinary team discussion, if you have access to that. And then again, treatment should be given if there is life-threatening organ involvement. So for example, if you have cardiac sarcoid, the patient is at high risk of arrhythmia, you probably need to do some form of treatment. And then the patient may actually need defibrillators or anything else implanted. So it's quite complicated in these cases. So when there is a high risk of organ failure, for example, if the lungs are severely involved, you also may want to treat. Also, if the patient asks for it, because they are very symptomatic, they have a lot of unpleasant symptoms, let's say, or unpleasant involvement. For example, the lupus pernio that affects their entire face, and they cannot go out of the house because of that. So those are things that you need to consider on a case-by-case basis with your patient, discuss, explain, have a good rapport to try to understand what the priorities are and when treatment might be required or when follow-up is the best choice. So the goal is to reduce symptoms or to restore, preserve organ function. But it's again a matter of significant debate when and to treat or when not to treat sarcoidosis. Topical treatment can be used sometimes. So for example, if you have only eye involvement, you can have, steroid eye drops, for example, prescribed by the ophthalmologist. Or if you have skin involvement, you may have some sort of a topical anti-inflammatory treatment that could work. So again, you're trying to offer your patient the minimal treatment possible. The reason for that is you need to always consider the benefit to risk ratio. You need to consider that there can be a potential spontaneous remission or there can be progression. You need to consider also that the first line of treatment is corticosteroids. So these are dirty drugs, let's say, because they have a high risk of adverse effects. And you need to be careful who you're giving steroids in high doses for a very long time, because if your patients have a high BMI, they have diabetes that's poorly controlled, high blood pressure, things like that, steroids can make these problems worse, and they may actually not be needed if the patient will spontaneously have a remission of their sarcoid. So this is very important to consider, to have this balance of risks and benefits in your mind all the time. Also, the treatment is long. So usually to achieve remission in sarcoid and stability of the disease, usually you would need to treat for 12 months or more. So there's no set dose of prednisolone, for example, of corticosteroids at which to start. Usually it could be 20 to 40 milligrams daily and then reduce slowly to the lowest possible dose, usually around 10 milligrams. And then you go even slower and slower when you're reducing to make sure that you're not having a relapse, basically. So you're always maintaining close follow-up, checking for symptoms, checking for side effects of medication, lung function, other organ involvement. There are second-line treatments that can be used, or steroid-sparing agents. So sometimes you would want to get your patients off the steroids as soon as possible and onto something else that also may have side effects, but maybe less frequent than the ones you would have with the steroids. Or there may be a reason why you don't really want patients to be on steroids. So things like methotrexate, azathioprine can be used. Hydroxychloroquine can sometimes be used in limited sarcoidosis with limited organ involvement sometimes. So all these medications can be used in different cases on a case-by-case basis. You can have in life-threatening sarcoidosis affecting the heart, for example, you may want to go for medications which are even stronger, let's say, or they work in different ways, but this should be reserved for specialist centers with a lot of expertise in the treatment of sarcoidosis. So I would say, if as a clinician you have any doubt about the treatment you should be giving your patient, or if you shouldn't be giving treatment, you should refer your patient to a center that has expertise in the treatment of interstitial lung disease and severe sarcoid. That's probably the best approach to not get in over your head, really. So the final thoughts I'd like to give you, and this is regarding the follow-up as well. The clinical course can be unpredictable, so follow-up is essential. It's absolutely essential. So if the disease is relatively stable, you know that the patient is well, they understand the disease well, you can probably follow up 6 to 12 months, every 6 to 12 months. But again, you need to, I would say this has to be agreed with the patient. So it's something that if they are comfortable with, you would set a follow-up schedule depending on their preferences as well, but inform them what to look out for, what sort of symptoms to look out for. If they can have maybe a local blood test with their doctor every now and then. So that those things need to be worked out with your patient on a case-by-case basis. Now, in other cases where the disease course is not clear, you're not sure what will happen, if the patient will get better or progress, or you feel that there are adverse signs, probably a follow-up which is even closer, so every 3 to 6 months is more appropriate. Again, depending on patient preferences and local arrangements where you are in the world. but a total length of follow-up of 3 years or more should be envisaged for sarcoidosis, because it's a condition that can seemingly go away but then return. So it's something that we need to be able to offer our patients the ability to come back and see us if things aren't going well. Now, obviously, after you discontinue treatment, if the patient was already treated, it's important to look out for relapses. So these can happen when we discontinue, sometimes when we stop too soon. Like I said, the treatment can be lengthy, so it's important to educate the patient, really, to discuss exactly what to look out for, what they should keep in mind, and to try to offer them the opportunity to come and see you as soon as possible if things aren't going well. Now, I've put here a couple of resources you can look out for further information on sarcoidosis. It's a very, very complex condition, so really do look out for these and other resources online. There are many articles about sarcoidosis, many review articles that you can find on PubMed, etc. But even websites like radiopedia.org, so if you look out for the sarcoidosis article or the thoracic sarcoidosis staging articles, you can just type these into your search engine and these will come up. These are very good things to start with. Now, there is a guideline by the ATS about the diagnosis and detection of sarcoidosis. That's really good as well. It doesn't cover treatment. Like I said, the treatment in sarcoidosis is a matter of debate even between specialists. So I would say if you're reading about the treatment of sarcoidosis, try to read from various different articles, because you might see different viewpoints, different doses of medication that have been used, or case reports. There's not a lot of evidence-based practice regarding the treatment for sarcoidosis. So this is something very important to keep in mind. Now, some of the things that I've mentioned in this slide, in these slides and this presentation, are taken from the ERS, European Respiratory Society's Handbook of Respiratory Medicine, which is a great book if you want to look into that, if you're interested in respiratory disease, because it's a very concise, they have very concise chapters with the basics of most respiratory conditions, and it's a good place to start, I think. So thank you very much for watching. If you would like further topics, things that you would like me to talk about in the future, do leave a comment below. Like I said, this presentation was less for patients, so if you're a patient suffering with sarcoid, I would suggest you talk to your doctor about detailed information in your case. I try to avoid using medical jargon as much as possible, but in these presentations, which are more tailored for medical students and people who are already working in medicine, I generally need to use these terms. So there are some other videos on my channel for patients, and I will try to signpost which content is for which audience if I can. Thank you very much for watching, and all the best and good health.